I am first removing the fat, the omentum which was adherent to the gallbladder. Robotic surgery is almost like an open surgery. You can see with very much stability in my hand, I am doing tremor free with stable hand movements. I can show you that the bile duct, which was the prominent bulging portion, is the bile duct that was dilated because there was a obstructing pancreatic cancer down below. The first step you can see is I am removing the gallbladder. I remove the gallbladder from the liver surface. That is you can see the gallbladder cystic duct. I'll take a stitch and close the cystic duct. The suturing is very good with any robotic platform. Now you can see I'm opening the bile duct. The moment I open the bile duct, you can see so much pus is there, and the patient was suffering. Now I divided the small intestine, the jejunum, with a stapler. Then I took one loop of the jejunum to near of the bile duct. You can see I am approaching, making a first layer and approaching the bile duct into the jejunum so that they stay with each other. Once the jejunum is apposed, then you can zoom in and stay close to the junction between the jejunum and bile duct. As you can see, I cut open the jejunum. Now I will join nicely, better than even open surgery because the magnification is much better. I'm joining the posterior layer of the bile duct and the jejunum. I'm putting interrupted stitches. No, here I am putting continuous stitches. This is a PDS 30 PDS. You can use both hands to put the needle inside. I finished the posterior layer. I'll continue continuously with the anterior layer. For me, doing surgery robotically is much easier. I can do with much more precision, like every little blood vessel. The bleeding which you are seeing is 10 times magnified. If you see in open surgery, that will be much less. But in robotically, you can it look bigger and more volume. So basically, what happens? We do the surgery bit by bit, controlling a little bit of ooze or the bleeding. So at the end of the surgery, the blood loss is less and surrounding tissue damage is less, so the patients have leisure pain and go to home early. And the results of surgeries are much better. You can see I am making an anterior layer also. So it is a 2-layer anastomosis without any tube, without any stain, and the patients usually do well. And this patient was post-operatively did very well, and he is anictric and he is very happy. After that, we made a jejunostomy with the sure-form stapler. As you all know, I am a fan of sure-form stapler. It gives a very good leak-proof anastomosis. Until now, it has not made me feel sad. It is always good. And with a barb suture, closing the rent in which we put the staple is much more good, leak proof. To make a leak proof anastomosis, I believe the technique is important, the tissue within the body should be healthy, and definitely the material what we use is also important. Plus the vascularity of the adjacent organ is important. It should be tension free. The basics of surgery, any anastomosis, it should be tension free, it should be equal lumen and with good vascularity. Hope you all like the way we do surgery robotically. Thank you so much for observing our work. Thank you.